Your immune system is a sophisticated and powerful defense network, naturally equipped to detect and eliminate threats, including cancer cells. CAR-T cell therapy, short for chimeric antigen receptor T-cell therapy, harnesses this innate potential by genetically modifying a patient's own T-cells, enabling them to recognize and precisely target cancer cells. This innovative form of immunotherapy involves extracting T-cells from a patient, engineering these cells in the laboratory to express a synthetic receptor, a CAR, specific for tumor-associated antigens. Then cells are expanded to therapeutic numbers and they're infused back into the patient to attack cancer cells. While CAR-T cell therapies have achieved remarkable clinical successes in treating blood cancers, such as leukemias and lymphomas, with numerous FDA-approved products achieving high remission rates, applying this therapy to solid tumors has proven significantly more challenging. Solid tumors, such as those affecting the breast, lung, brain, pancreas, and other organs, present distinct obstacles that complicate the effectiveness of CAR-T cell therapy. One major challenge in solid tumors is the tumor microenvironment, or TME, characterized by immunosuppressive conditions that actively inhibit the function of T cells. This environment includes various suppressive cells such as regulatory T cells, or reg T cells, myeloid-derived suppressor cells, and immunosuppressive factors such as TGF-beta, interleukin-10, and others to reduce CAR-T cell efficacy. Additionally, we have physical barriers such as dense tissue, abnormal vasculature, high interstitial pressure that impede infiltration and effective distribution of CAR-T cells within the solid tumor. Another significant challenge is tumor heterogeneity, meaning not all cancer cells express the targeted antigen, allowing some cells to evade CAR-T cell detection. This issue, termed antigenscape, is particularly pronounced in solid tumors where variability in antigen expression is quite common. For instance, in glioblastoma and other aggressive cancers, antigenic variability complicates the design of effective single-target CAR-T therapies. Clinical trials for CAR-T in solid tumors have been cautiously progressing. Promising strategies currently explored in ongoing trials include multi-targeted CAR-T therapies designed to recognize multiple antigens simultaneously, thus reducing the risk of antigen escape. One noteworthy trial involved dual-targeted CAR-T cells engineered to attack EGFR and IL-13 or alpha-2 in patients with recurrent glioblastoma, demonstrating tumor shrinkage in initial patient cohorts. Another innovative strategy involves engineering CAR-T cells to activate specifically within the hypoxic environment with low oxygen, characteristic of solid tumors. Hypoxia-inducible CAR-T cells are designed to remain inactive in normal oxygen-rich tissues, reducing the risk of on-target off-tumor toxicity, while activating and exerting their tumor-killing functions selectively in hypoxic tumor regions. Preliminary studies suggest that this approach could significantly enhance specificity and safety. Combination therapies represent another important area of research aimed at overcoming the immunosuppressive microenvironment and boosting CAR-T efficacy. Clinical trials combining CAR-T cells with immune checkpoint inhibitors, radiotherapy, or cytokine therapy, for example, have demonstrated preliminary safety and efficacy, highlighting potential synergistic effects. For example, CAR-T cells combined with PD-1 blockade have shown improved activity in preclinical and early clinical settings, enhancing the immune response against tumors. Manufacturing advancements are also critical to CAR-T cell therapy's future. Automated closed-system bioreactors capable of producing CAR-T cells rapidly and reliably are being developed, significantly reducing production time, costs, and logistical complexities. Furthermore, research into off-the-shelf allogeneic CAR-T cell products made from donor cells rather than individual patients and innovative in vivo CAR-T cell generation methods, which involve direct genetic modification of T cells within the patient's body, hold the promise of making CAR-T cell therapy more accessible and scalable. To date, no CAR-T therapy has received FDA approval for solid tumors, although cell therapies such as tumor-infiltrating lymphocyte or TIL therapy for melanoma and T-cell receptor TCR therapies for synovial sarcoma have achieved regulatory approval. These successes have provided important validation for the broader potential of cell-based therapies in solid tumors. Case studies from clinical trials illustrate the potential for significant clinical responses. For example, notable tumor reductions observed in early phase trials for glioblastoma and neuroblastoma patients receiving experimental CAR-T cell therapy underscore the promise of this approach. These cases provide valuable insights into the factors critical for achieving sustained responses, including targeted multiple antigens and delivering cells directly into tumor compartments. Continued evolution of CAR-T cell therapy holds significant promise for transforming the treatment landscape for solid tumors, providing new hope for patients with cancers that have historically been resistant to conventional therapies. Thank you.